Anyway, some of you might have heard me being introduced this morning, but if not, then let me just point out that I'm in New York and also at Albert Einstein College of Medicine. I'm a neurologist by training, professor of neurology at Albert Einstein, and I run the sleep center in New York City. Okay, so what I'm going to do is I'm going to talk a little bit. I'm not covering everything in narcolepsy, obviously. There isn't enough time, because I do want to leave time for some questions. But I'm going to talk a little bit about diagnosis. And I've sort of come to a view on diagnosis of narcolepsy that might be a little bit different to what a lot of other physicians in the field believe. And I'll sort of explain that as I go through. Also, I'm going to talk a little bit about pregnancy. I was asked to say some words on pregnancy and narcolepsy, so I'm going to say a bit about that. Do have some experience in so much as having published in that area. And then finally, I'm going to talk about treatments and up-and-coming treatments for narcolepsy. Okay, so narcolepsy. Now, I call this narcolepsy and variant disorders. And I personally believe that there are some patients that fall into this category that in fact have narcolepsy. And it really depends on what your definition of narcolepsy is. And I'm going to tell you what the diagnostic criteria are for narcolepsy, how most of you who have narcolepsy is diagnosed. But just out of interest, are there any people in this audience who have this as a diagnosis? There are some of you, yeah. Okay, and some of you may have had it before you got either this or this diagnosis. So it depends what your definition of narcolepsy is. And I believe that narcolepsy is a disorder of hypocretin production. And hypocretin, I'm sure most of you know what hypocretin is at this stage of the conference, but if you don't, it's a neuropeptide which is produced in the brain, in the hypothalamus of the brain. And people with this form, narcolepsy type 1, generally have a severe reduction of the cells that produce this chemical, or the cells that produce it are totally lost. The question is, what do these people and these people have? And I believe that certainly that many of these people have a loss of hypocretin cells, and I'll explain why. And I think some, if not all, of people in that category probably do too. Okay. So narcolepsy, and again, I sort of mentioned this morning for those of you that were in the audience, but this is now showing it in print. You know, I think of sleepiness a little bit differently than maybe most people think of it. And I like to think of narcolepsy as being, having the sleepiness of narcolepsy having 4 components. And of course, sleepiness is the prime symptom in narcolepsy. So that everyone with narcolepsy has sleepiness. And there's a background level of sleepiness, and this is there all the time and never goes away. You know, I like to tell physicians when they come to make a diagnosis of narcolepsy, if you have a patient who has sleepiness and they go on vacation and they never have any problem with sleepiness at all, or have 2 weeks without sleepiness, then they don't have narcolepsy, because it's always there. It may be better on some days, and it may be worse on others. But there's a background level, and it's tiredness, fatigue, and maybe even more severe sleepiness in many patients. But then there's this involuntary sleepiness, where some people, and not everyone with narcolepsy has it, where they just have these irresistible episodes of sleep, and they have to give in to it, and they have sleep attacks, so-called sleep attacks. And therefore, if they're doing something, they have to give in and take a sleep. And this can happen during activities such as while eating, you know, standing, and other types of activities. And then there's voluntary sleepiness, where people will purposely take a nap. And the distinctive feature, I think, about the sleepiness in narcolepsy is that it often occurs in the morning. And as distinct from the afternoon. And in fact, I think it's, if somebody never has sleepiness in the morning before noon, I think it's unlikely that we're dealing with narcolepsy. So taking a nap or feeling sleepy or being able to fall asleep before noontime is very typical in patients with narcolepsy. And generally those naps are refreshing, but not always. And I know many of you probably have naps that are not refreshing. And some people prefer short naps, some prefer long naps, and there's a lot of variability there. And then there's this partial, what I like to call, and this is my terminology, is partial sleepiness. And these are these micro sleeps, little 1 to 2 second sleep episodes occur while people are doing things so that they can have activities where they do things and they have no memory for doing it, and then later they think, gee, I did that, but I just don't remember doing it. And these are these little automatic behaviors, and this is a partial sleepiness because they're sort of awake and asleep at the same time. So this type of description of sleepiness, I think helps physicians and would be good for physicians to help them understand a little bit more about the sleepiness of narcolepsy, because typically it's not really spelt out so much. And you know, physicians typically ask, you know, do you fall asleep when watching television? Do you fall asleep when reading a book? And if the answer is no, then they move on to something else, such as cataplexy. Do you fall asleep, or do you get weak if you laugh? And if the patient says no, then they say, oh, you can't have narcolepsy. But I think we need to tease it out a bit, and we ask a few more questions and think about these types of situations for sleepiness. Okay, so sleepiness everybody has, and then we have this type 1 narcolepsy. And this is the diagnostic criteria. And you don't need to read it, I'll spell it out, but basically you need to have that sleepiness for at least 3 months. And then for type 1 you have cataplexy, emotionally induced muscle weakness. And in addition to that, you need to have sleep studies that typically on the daytime test, you have a mean sleep latency of 8 minutes or less, which means you fall asleep quickly during the day and nap opportunities. And on at least 2 of those naps you go into REM sleep. And that's sort of the classic diagnostic criteria for narcolepsy. It's been changed a little bit lately because we recognize now that you can go into REM sleep at night within 15 minutes, and 50% of patients with narcolepsy type 1 will tend to do that, 50%. And that's a helpful diagnostic point if people do go into the REM sleep so quickly, because normally it takes us about 90 minutes before we go into REM sleep. But if they do it within 15 minutes, it's highly suggestive of narcolepsy. Now, alternatively, instead of having the cataplexy in these sleep studies, you might have a CSF hypocretin, but probably very few of you. Anyone here had a hypocretin level taken? CSF hypocretin? No. It's pretty rare. I mean, there are only a few research centers that tend to do that, but most people don't like to have a needle stuck in their back for obvious reasons. So it doesn't get measured, but maybe sometime in the future there might be some easier way of doing it or getting a hypocretin level. So anyway, this is what we call type 1 narcolepsy. It used to be called narcolepsy with cataplexy because most of these people fall into A and B1, but because you could have A and B2 without cataplexy, there are a few extra patients in this category that don't fall into narcolepsy with cataplexy group. Well, that diagnosis largely depends upon cataplexy because most people aren't going to have a CSF hypocretin. So it depends on cataplexy. And the difficulty with cataplexy is when it's obvious, it's obvious. I mean, if somebody laughs and they fall to the ground, it's pretty obvious that it's cataplexy. But for most patients, they don't laugh and fall to the ground. And this cataplexy can be subtle. And that may be a reason why many of you probably had a delay in getting diagnosed because physicians didn't recognize what cataplexy was or how to pick it. And certainly buckling of the knees so that you get weakness and is a very common symptom in patients with narcolepsy. But of course, most physicians, when they're sitting at their desk, the patient's not standing, so they never get to see cataplexy. But what I try to emphasize to physicians is to take their eyes away from the medical records a few times, because nowadays everybody is so focused on filling out these screens, they never look at the patient. But if they look at the patient, sometimes you can see cataplexy if the patient gets a little emotional, and you see it in the head and neck. And that's often a very important thing. And I like this sort of slide because it emphasizes the head of the neck, and you have to be aware of subtle features of cataplexy, a little bit of head nodding, a little slurring of the voice, sometimes twitching around the eyes, twitching in the face, maybe a manifestation, or the eyelids coming down, or the head drooping a bit. So subtle features of cataplexy, but this diagnosis, NT1, depends on having that. And many physicians may not see it or may not recognize it. Many patients often don't recognize it. I mean, you may have had the experience where somebody else, a family member, notices what happens to you when you laugh, and they notice that your face doesn't sort of smile the way it should, a little bit of facial droop, and you may not even be aware of it yourself, maybe what the family mentions. So cataplexy, such an important thing in making this type 1 diagnosis, yet it's a symptom that is so difficult to recognize in many patients. So it's not surprising that we have a lot of patients who get misdiagnosed or just don't get diagnosed. Now this shows, this is a little graph showing the presence of cataplexy after the onset of sleepiness. And this is actually measured in relationship to hypocretin levels. But what this basically says is that some patients can develop cataplexy up to 24 years or so after the onset of the sleepiness. So if you just have sleepiness, you might be in that category of type 1, but you've never had a CSF hypocretin level measured, so people don't know. But because you haven't developed cataplexy yet, then you don't get that diagnosis. So that's a problem. And one of the things, the point that I'm making is that our current diagnostic criteria are problematic. And they don't make it easy in terms of making diagnoses of narcolepsy. And particularly, as I say, in some patients, it may be many years later they develop the cataplexy. Okay, so if you don't have cataplexy, what diagnosis do you get? Well, if you meet that criteria on the sleep studies, then you're going to get a diagnosis of type 2. And fortunately, most of the insurance companies will tend to recognize type 2 narcolepsy if you have these sleep study findings. And so if you have cataplexy, and a lot of them ask about cataplexy, and there are certain drugs like, for example, Xyrem, some insurance companies won't approve the patient getting Xyrem if they don't have cataplexy, even though they have type 1. So insurance, unfortunately, pays attention to these diagnostic criteria. But again, the point is that the diagnostic criteria are not ideal, and therefore someone is going to miss out, and unfortunately it'll be the patient. So this is type 2, no cataplexy, but having sleep study findings. And then we have this third category, idiopathic hypersomnia. And these are patients that are sleepy, but there are sort of two different types of it, and that's why I'm not sure yet, and we don't know yet whether both types could be related to narcolepsy or totally different. At the moment, people think of it as different to narcolepsy. And unfortunately, the symptoms can be almost identical, except for not having cataplexy, of course, but can be just as severely affected in terms of sleepiness. And unfortunately, the insurance companies say, well, you don't have narcolepsy, therefore you can't get the narcolepsy drugs. So in a way, it's kind of good to be a splitter, having these different diagnoses, but in another way, it's bad. It's bad for the patient. So basically, these people have the same degree of sleepiness, as indicated at the top, don't have cataplexy. They have sleep studies, but they don't get those criteria, don't get the mean sleep latency. They get the mean sleep latency that's low of 8 minutes or less, but they don't get the sleep onset REM periods. And they might have one sleep onset REM period. And that doesn't meet the criteria for narcolepsy. So it's a sort of a problematic sort of diagnosis. There are some patients who have long sleep at night, but there are other patients who fit this criteria who are just like narcolepsy patients but don't have the cataplexy. Now, the reason to sort of put some caution into, well, really what is diagnosis of narcolepsy was based on this information. This is a patient that was published about a year ago or so, at the end of 2014. And what it was a patient who was very sleepy, came in and had these sleep studies for narcolepsy, and they were negative. The patient was sleepy on the sleep studies, but didn't have REM onsets. And they did a CSF hypercretin, and it was within the normal range. So they said, oh, this patient can't have narcolepsy. We'll call it, meets the criteria for idiopathic hypersomnia. However, 2 years later, the patient came back, and this time they had 3 sleep onset REM periods. Didn't have a CSF hypercretin measured, but then the doctor said, oh, well, patient now meets the criteria for type 2 narcolepsy, NT2. And then 2 years later, patient came back again. The sleep studies were much worse, 5 sleep onset REM periods, but now the CSF hypercretin was low. And the patient was reporting features compatible with cataplexy. So they said, oh, this patient now has type 1 narcolepsy. So this is what they call progressive narcolepsy, that it went from idiopathic hypersomnia to narcolepsy type 2, then to narcolepsy type 1. Okay, so our diagnosis is dependent largely upon recognizing that cataplexy and upon these sleep study results. But basically what I'm saying here in this is that we know that many people who don't have narcolepsy actually can meet the criteria for narcolepsy on sleep studies. So that shows that we have what we call false positives. And there are many patients who have narcolepsy and they just don't get the 2 sleep onset REM periods, and they don't get the low sleep latency. And so, but on another day, they might well show those features. But because of the fact they're on medications, or because of some anxiety, because the environment wasn't good, the sleep study recording room was noisy or whatever, the test was negative. So they don't get a diagnosis of narcolepsy. So we know we get false negatives with regards to the multiple sleep latency test. And if you repeat the multiple sleep latency test in many patients who are positive for narcolepsy, the next time it's not positive. So there are limitations in terms of this test, and it's sort of unfortunate that we have the multiple sleep latency test as our diagnostic sort of standard for narcolepsy. Now what actually happened was that the patients who have cataplexy, you know, it's very clear they have narcolepsy. There's no question about it. And they did this MSLT. They found they had mean sleep latency less than 8 and 2 or more sleep onset REM periods. And then there were these other patients who didn't have cataplexy, and they said, well, let's just apply the same MSLT criteria as we do for type 1 to type 2. So it was an arbitrary decision to do that. And unfortunately, I think that's a little bit of a problem. Now, there are other factors that are involved in narcolepsy. We know that most people have a genetic predisposition for narcolepsy. They have this histocompatibility antigen, what's called the HLA-DQB10602. And the people who have cataplexy and who have low hypercretin are more likely to have that particular genetic factor. But not everyone. As you can see, up to 90% of patients will have it, but there's 10% who clearly have narcolepsy, clearly have low hypercretin levels, and don't have that genetic abnormality. So it's mainly found in the type 1, but in the type 2, we find it, but it's more than you would find in the general population, 16.6 versus 7.8. So it's higher than you would find. So it looks as though there's a predisposition for that. And some of the patients in type 2 do have low hypercretin levels. Right? Now that get reassigned to being called NT1, but those that never got the hypercretin measured, 15% of people with NT2, if you were to measure it in everyone, you'd find 15% have low levels. So they're type 1. And then we have idiopathic hypersomnia. And their genetic predisposition is no different from controls, and in general they have normal hypocretin levels. So we have differences between these three groups in terms of a genetic makeup. And this is the hypocretin levels. Now, normals, these are the hypocretin levels. In patients with narcolepsy, most people have no hypocretin. A lot have below this 110, which is counted as the cutoff. But then there are other people who have cataplexy who, as I say, have normal hypocretin levels. And if you look at narcolepsy without cataplexy, there are a few people who have low levels, and then majority are within the normal range, and same with idiopathic hypersomnia, except for none of them have low levels. Now, the problem with hypocretin is we're measuring it in the CSF. In order to get a low hypocretin level in the CSF, you have to lose, again, that same figure, approximately 90% of the cells producing hypocretin in the brain. And if you don't have 90% of those cells lost, then you're going to have a normal CSF hypocretin. So it raises the question, what about patients that might have 80% loss, 70%, 60%, 50, 40, 20? What about them? And we don't know the answer to that, because in order to get that, we'd have to look at the brains of people who have narcolepsy type 2, who don't have cataplexy, and see how many cells they've lost. There is some evidence, and I didn't have to put that slide in, but there is some pathological evidence in a patient who died with narcolepsy type 2, and they did look at the brain, and they found that he had 50% loss of hypocretin. So 50%. So he would have had a normal, he didn't have a CSF hypocretin measured, but if he had have had a CSF hypocretin, it would have been normal, even though he lost 50. So the big question is, are we looking at a condition that has a gradation and a variation in terms of loss of hypocretin? And I suspect that that's the case. And I think, what I believe is that if you have that genetic makeup, the HLA, and there's also another genetic factor called the T-cell receptor alpha locus. If you've got that genetic makeup, you're more likely to go on and develop the full picture of narcolepsy. Some of these patients are going to have the same genetic makeup, but they may not have lost as many cells for one reason or another. And then many of these people don't have that genetic makeup, but they may have had the same sort of insult that causes narcolepsy, and they may have lost some cells of hypocretin. It's just that we have no way of knowing it, because the CSF is normal, but it doesn't mean to say their cells in the brain are lost. So I believe that narcolepsy is a variant disorder, that at one end of the spectrum you have narcolepsy with cataplexy, at the other end you have idiopathic hypersomnia for many patients, and in between you have this type 2. So we need to have better diagnostic criteria, which unfortunately we don't have. And that's why I think narcolepsy is more of a disorder of loss of hypocretin cells rather than the symptoms, rather than the sleep study findings. Now, in making a diagnosis of narcolepsy, there's a lot of information that we can get besides sleepiness and cataplexy. And unfortunately, a lot of physicians ignore this. I've sort of summarized some of it here, but you're aware of this: the hypnagogic hallucinations, sleep paralysis, the dreams. A lot of physicians don't ask patients with narcolepsy about their dreams, but there are certain features of dreams in narcolepsy patients that are different. Like, for example, 88% can have what's called delusional dreams, dreams where you wake up and then you think something really happened until later in the day you realize, well, it didn't really happen, it was just a dream. So that can happen. Lucid dreams, where you can change the content of a dream. Out-of-body experiences, where you can see yourself sleeping and you're floating in the air. Or dreams of flying. Some patients have lots and lots of dreams flying all over the place. And again, that seems to be more common in patients with narcolepsy. So there's differences in the dream content, and of course dreams often occur in naps, which doesn't happen in normal people. And unfortunately, physicians in general don't sort of ask this, but finding these sorts of features in a patient who has consistent sleepiness even if they don't meet the criteria for type 1 narcolepsy, certainly can help you make a diagnosis of type 2, and may be effective for some patients with idiopathic hypersomnia as well. Okay, so again, my feeling is it's a variant disorder. What sets it off? Probably an infection. The increasing evidence is on infection. We know that streptococcal antibodies are higher in people with narcolepsy. There are isolated reports of Lyme's disease, infectious mononucleosis causing it. And I think Judith Owen this morning mentioned about HPV virus that some patients had reported developing narcolepsy after getting that. I don't know about that, and she doesn't know about that either. But, I mean, it looks as though everything is pointing. We know that it can occur after the influenza virus. In Japan, they saw a big increase after the N1H1 virus infections in 2009. And, of course, we know in Scandinavia that it's been associated with H1N1 vaccination. You're going to be hearing more about that, I understand, after my talk. So you're going to hear more. So anyway, there's some insult that occurs that sets off an autoimmune response causing destruction of hypocretin cells. So narcolepsy is an autoimmune disorder, predominantly in people who are genetically predisposed in some way, and probably precipitated by an infection and causes destruction of hypocretin cells. But I believe that there are many patients that probably have narcolepsy who don't get a complete loss of hypocretin cells, have partial loss, and may not have the genetic makeup that makes it more likely that they're going to lose a lot of these hypocretin cells. But I guess time will tell. Okay, so now I'm going to talk a bit about treatment. And goals of treatment, obviously, to reduce sleepiness, control the main symptoms of narcolepsy, improving quality of life for everybody, and making patients safe. And there are a variety of treatment directions. You all know that caffeine is a stimulant. And then there are some pathomimetic drugs, which are sort of the drugs like the amphetamines and methylphenidate. Then we have the various modafinils, probably working through a dopamine mechanism. Then there are new drugs, histamine receptor inverse agonists, hypocretin drugs, and then GABA-A agonists. Okay, standard treatment. At the moment, the primary treatment for narcolepsy is regarded as modafinil and sodium oxybate for the sleepiness. And these are relegated, these amphetamines and methylphenidate, to a much lower sort of level of recommendation. In terms of the cataplexy, the only drug FDA approved is sodium oxybate or Xyrem. But again, antidepressants can be very effective, and many of you will be on antidepressants alone or in combination with sodium oxybate. So a little bit about some of the drugs for narcolepsy. Armodafinil is now being used more than Provigil. Some insurance companies demand armodafinil rather than Provigil. Some do the opposite. Some say we will approve Provigil and not Nuvigil. So it goes both ways depending upon the insurance company. The advantage of armodafinil is it's a once-a-day formulation. One tablet of armodafinil or Nuvigil is effective, clinically equivalent to about 2 tablets of modafinil. So it's 1 tablet versus 2. So there are a number of advantages. Cost-wise, it's about the same. And in fact, I think Nuvigil is often just very slightly cheaper than Provigil. Biggest problems I've mentioned here, generally it's well tolerated, but for women of childbearing age, of course, it can affect oral contraceptives, and so can, because it increases the hormone ethinyl estradiol, can render them less effective. And there are rare cases of severe rashes and allergic reactions, and that can be really bad if that happens. But in general, well tolerated and good drug that many people use. Then I'm just going to mention one of the stimulants, and I'm going to mention Adderall because Adderall seems to be being used more and more these days. Seems to have quite a good sort of safety profile. And just to point out that it is 4 different amphetamines mixed together. And there's an immediate release and an extended release. Only the immediate release is indicated for narcolepsy, so many times a physician will write for Adderall XR, and the insurance company will say, no, we won't approve it for a patient with narcolepsy because it's not actually FDA approved for narcolepsy. And the physician needs to realize, well, if we go back and try for the IR, the immediate release form of it, then it will get approved. Why they will approve one and not the other, I have no idea, because many patients do like the extended release because it's once a day rather than several times a day. Then there's sodium oxybate. And sodium oxybate or Xyrem is the only drug that treats all the symptoms of narcolepsy. Improves nighttime sleep, can eliminate cataplexy, reduces the dreams, the hallucinations, the sleep paralysis. Nothing else will do it other than Xyrem. Only drug. It also has an effect on improving cognitive function. Thinking, mental components of what we call executive function. And we don't understand really about that because we don't have good measures and it hasn't really been formally looked at. But there's one thing that most people don't know about stimulants. And that is that stimulants, and this includes amphetamines, methylphenidate, modafinil, they improve your ability to stay awake. If you want to stay awake and do something and you take those drugs, they can improve it. But you can still fall asleep, as I'm sure many of you realize. You can still fall asleep despite it. And if you lie down in a darkened room, you can fall asleep pretty quickly. And even with the strongest of the amphetamines, methamphetamine, which is the strongest form, people can still do that. They can still fall asleep when put in a darkened room, even though they got a big dose. So it improves the ability to stay awake, but there's always this background level of sleepiness. And what many of you experience is that you're aware of that background level of sleepiness. Even though you've taken these drugs, you feel, gee, I can do better, I can function better, but there's this horrible feeling there all the time of the sleepiness that never goes away. In Xyrem, in most patients, that tends to go away, and that's quite different to the stimulants. We don't have, as I say, we don't have a good way of measuring this, but I think that it's this background level of sleepiness that interferes with cognitive function, and that's why patients with Xyrem, when they do well on Xyrem, why they do better, because that's not there. So it's an additional feature that we see with sodium oxybate that we don't see with the other drugs. Then there are the antidepressants, of course, and many of you are on these, venlafaxine, atomoxetine or Strattera, for example. But they can cause sexual side effects, disturb nighttime sleep. They don't help the other symptoms of narcolepsy at night or the daytime sleepiness. So, can be effective just for cataplexy, no question about it, but there are other potential problems with them. So my feeling is about treatment is that Xyrem, I believe, is the first best line drug for narcolepsy, for both type 1, type 2, and possibly for many people with idiopathic hypersomnia, although we just don't have that data yet, but probably for some idiopathic hypersomnia patients. And then second line, I believe, for the sleepiness of the modafinils, cataplexy, venlafaxine, atomoxetine for the cataplexy. And, these are required. If somebody can't take it, and there are many patients that can't take Xyrem, I'm sure many of you have tried it, you just can't take it, then these become all the more important. Sometimes these need to be added in with sodium oxybate. In fact, the best data we have in terms of improving sleepiness is a combination of sodium oxybate and modafinil. And presumably armodafinil, although they didn't do the same studies with armodafinil, but sodium oxybate plus modafinil gets the biggest improvement in terms of daytime sleepiness. Okay, I was asked to say a little bit about pregnancy, and then I'm going to talk about future directions in treatment. So this is a paper that I published a couple of years ago. I refer it to you because you may want to look it up, some of you who are in childbearing age. I do occasionally give patients mine the copies of this, or they go and look it up and print it off, because it is, I think, the most comprehensive article on drugs and pregnancy and narcolepsy. And basically, I'm not going to go into it in detail, but I'll mention some of the features. But the bottom line is that there's no evidence that any of the narcoleptic medications, when taken in therapeutic doses, adversely affect either the mother or the baby, right? Although the general recommendation by every physician is obviously if you can stop all drugs during pregnancy, you should do that. But many patients can't stop their narcolepsy treatment. This is just showing that this is no longer available. Pemeline, which was a better category, but these are all the same category, meaning that there's no evidence in humans that they can cause any problems, but there are precautions about it in terms of pregnancy. So in terms of medications in the fetus, most physicians, I think, perceive the risks to be much worse than they are with these drugs. I think they overestimate it. I mean, some physicians will say, well, it doesn't matter how bad your narcolepsy is, you've got to stop. You can't go on these medicines. And I think that's because they really don't understand what the data is, because the data does not sort of indicate that. Certainly if somebody's going to avoid it, it's at the beginning of pregnancy. It's a better time to avoid drugs rather than later in the pregnancy, because drugs, not these drugs, but other drugs have been shown to have their greatest effect there. And the risk of any teratogenic abnormal effects of narcolepsy in therapeutic doses, as I say, is essentially non-existent. And in terms of pregnancy and narcolepsy, if you have narcolepsy, it does mean you're going to have more problems? No. No clinically significant increased complications in pregnancy in narcolepsy patients. There are occasional patients who have cataplexy during delivery. There are some patients who have gone on to have cesarean because they have such severe untreated cataplexy that the gynecologist feels that it's better, obstetrician rather, feels it's better to do a cesarean. But for most patients, there's no problems during pregnancy. So most have vaginal delivery without complications. So really, it can cause a problem. And but if a cesarean is required, there are no increased anesthetic or surgical risks of having a cesarean in a narcoleptic. Breastfeeding. Sleeping pills are strongly recommended not to be given to breastfeeding mothers, and so for that reason sodium oxybate is recommended because of its depressant effect not to be given. It's been reported that in breastfeeding mothers, some of the newer antidepressants are generally safe to use, and stimulants in therapeutic doses don't seem to be harmful in breastfeeding mothers as well. So there are some patients who are on sodium oxybate who choose to continue sodium oxybate when they're breastfeeding and during pregnancy, and they will often express milk before they take their dose. And this is a recent study that looked at blood levels of sodium oxybate or gamma hydroxybutyrate, and then the same thing in breast milk. And they found that the amount in breast milk paralleled what was in the blood. And sodium oxybate has a very short half-life, 60 minutes, so it's all gone, as you can see, about 4 or 5 hours after taking a dose. So based on this, it means that about 5 hours after taking sodium oxybate, it's no longer found in breast milk. So many mothers will tend to express milk before they take their dose, because that's the time when they're likely to have breast milk without sodium oxybate in it, and then take their dose of sodium oxybate, and then use that milk for the baby during the night. Okay, so finally I just want to talk a little bit about new medications that are under investigation. And the ones of particular interest are the first one, monoaminergic reuptake inhibitors and histaminergic drugs, and then with hypocretin-based gene therapy and hypocretin peptide agonists. So this is a study this should say a Taxon 3 mouse, not 2-3, but Taxon 3. What this is a rodent study, and I sort of made reference to this morning. What they did is here's a mouse that has normal hypocretin. All the black spots is hypocretin. This is a mouse which they altered so that it destroyed the hypocretin cells. So there's no hypocretin in it. Then they gave it a viral vector, including the orexin gene, and this is the hypocretin that resulted afterwards in a couple of different sections of the brain. So it raises the possibility that there could be a cure for narcolepsy in the future if this type of technique could be applied to humans, giving the hypocretin gene through a viral vector and then recreating hypocretin. Okay, pitolisant. This is this histamine receptor inverse agonist. What it does, histamine increases our alertness, like dopamine is another neurochemical that increases our alertness. This is pitolisant, and this is a drug not available in the US, available in Europe, probably going to have some studies done here in the United States to approve this. But basically, the effectiveness on sleepiness by that Epworth Sleepiness Scale is about the same as with modafinil. So it is effective improving sleepiness, and there are some patients who actually also get their cataplexy improved. So for some patients, there may be an advantage of this in that it can help the sleepiness and also help cataplexy. So it's, it's a potentially a drug that may be useful and be additive to what we've got. Obviously its effect is not outstanding, it's not greater than anything we've got, but there is some advantage in having a drug that'll improve sleepiness and improve cataplexy taken during the daytime, because we don't have one that will do that at the moment. Then there's this drug that's undergoing some studies, and some of you may have been in this. There's a new drug by Jazz Pharmaceuticals called JZP-110. And what this drug, the studies tended to show that it's is very effective in terms of its effect on sleepiness. It's only for sleepiness, and it's very effective. So you can think of it like a sort of a modafinil, but the data tends to suggest it's more effective than modafinil. In fact, the data suggests that this may be more effective than any other drug we have at the moment for sleepiness, including amphetamines. The data seems to be better than the data for amphetamines in improving our alertness. So it's an exciting product that we don't know if it's going to get approved yet because it's still in studies, and maybe at least 18 months away before it becomes available if it is approved in pharmacies. But it does, it may be a medication for improving sleepiness during the day that's a big advantage over what we have at the present time. And what it does is it affects, like most of the medications that improve alertness, the amphetamines, the methylphenidate, the modafinils, it increases dopamine levels in the brain. But the other thing about this is that it increases noradrenergic effect. And norepinephrine turns off the sleep nucleus. So you're getting a dual effect. You're getting one effect stimulating wakefulness, another effect turning off sleep. And that's an advantage over other drugs that we currently have. And interestingly enough, if you remember my comment I made earlier with regards to sodium oxybate and the effect on cognitive function, there are some patients in the studies that tend to suggest that this may produce a similar effect in that it can improve, make them feel much better. Make them feel better, and maybe that sleepiness feeling in the background may no longer be there. But we don't know. We'll have to see if it does have a similar effect, because turning off that sleep nucleus may be a novel way of treating the sleepiness in narcolepsy. And maybe that sleep nucleus effect that's still there, even though you're giving a stimulant to keep awake, but there's still got that sleep drive. That may be why people feel this background level of sleepiness. And if you can turn that off at the same time through a norepinephrine activity, maybe patients will feel a lot better. So it's quite exciting that may become available. Then there's this drug, receptor agonist, the first hypocretin agonist that stimulates there are two receptors for orexin or hypocretin, and this one stimulates one. But again, many years away from being available. It's only just been discovered, so there's lots of safety studies have to be done, clinical efficacy studies, but it holds hope for the future that some replacement of hypocretin may become available. And then finally, there is another drug that studies are being done on, about to start, and it's sort of like Xyrem, but it's a once-a-day formulation, and I'm sure many of you know about that, by Flamel Technologies. And it's a drug that's giving sodium oxybate once before sleep, so you don't have to wake up in the middle of the night and take a second dose. No studies, and I encourage you, anyone that's never been on Xyrem, if you're really interested in exploring that, to find out about those studies. They're probably going to start at the beginning of the year, this coming year, in the United States. They've already started in Europe. But It has that advantage of just being once a night rather than having to wake up and take a second dose. But if you've been on Xyrem, unfortunately, you can't take it. It's only for people that have never been on Xyrem. Okay, so in conclusion, narcolepsy, it's an autoimmune disorder associated with hypocretin cell loss. Idiopathic hypersomnia may be a variant of narcolepsy, and we won't know the answer to that till in the future. Infection may be the commonest precipitating cause of it. Sodium oxybate appears to be the most effective medication for the treatment of narcolepsy at the present time. Alternative treatments are the modafinils, particularly armodafinil, and norepinephrine reuptake inhibitors like venlafaxine and atomoxetine. And in pregnancy, narcolepsy medications and therapeutic doses have not been shown to be harmful to either the mother or the fetus. So I'm going to stop at this point, and I'll be happy to answer any questions. Thank you very much. I think you had your hand up first.
Yeah, but the last medication that you talked about, you said it was not available for people who had previously taken Xyrem. Is that even if you haven't taken Xyrem for many years?
Unfortunately, yes. If you have ever taken Xyrem, you can't be in those studies. Well, yeah, it's complicated. But that's the bottom line. If you've tried it, you can't take it, unfortunately. There was a question over, over the, okay, at the front then.
I didn't quite catch, is the JZP
110? Mm-hmm.
something, is that what might be available in the beginning of the year? Or is that
No, that's, the studies are ongoing at the moment, and it will be, probably that's not going to be available for another 18 months. The studies are sort of going to be winding up over the next 6 months or so, but it'll be 18 months before it's available.
What would be available in the beginning of the year?
Nothing. The studies that are starting with this new single-dose formulation are going to be starting at the beginning of this coming year, so or the end, right at the end of this year, beginning of the year. So, you know, now's the time to inquire if there are patients that are interested in getting involved in those studies. Yep. I'm sorry? Oh, if the mother had Lyme's disease, could the baby get narcolepsy? Absolutely no evidence for that. The number of cases are just isolated cases, so we haven't seen or heard reports of many cases of people having Lyme's disease. But it's just that there are those cases. There are also, you know, cases of infectious mononucleosis, all variety of different infections. There are reports of these happening before the onset of narcolepsy. Unfortunately, most physicians don't ask about it because what happens is that by the time you get to see your sleep specialist, who's the one that's going to ask you, if anyone's going to ask you, it's often several years since you had the onset of sleepiness. And of course, it doesn't come up with what happened several years ago. And often patients don't remember if they had some bad flu back then or anything like that. So we don't have good information on it, but all the evidence is suggesting that some type of infective insult sets it off. And it seems as though it's probably a variety of different insults, although some more than others, particularly with the H1N1 virus, the H1N1 vaccine seems to have precipitated a lot of cases. So some things are going to make it worse, but other infections might be involved too. You're over the back here. You've been waiting for a while. I mean, there's a very strong pressure for sleep for many people with narcolepsy, and it can be for either REM sleep or it can be for non-REM sleep, normal sleep. But just relieving that with a nap, usually a short nap, what we recommend is less than 20 minutes, is often refreshing, but short-term refreshing. It's not long-term. So it's not as though you take a nap and you're good for the rest of the day, unfortunately, but it's going to relieve that pressure at that particular time. But there's a lot of, as I mentioned, a lot of individual variation. Some patients find short naps, some longer naps, and so it does differ from patient to patient. But in general, it's not getting rid of the background. It's just getting rid of that strong REM pressure at that particular time. Right at the back.
I came in late, so I apologize if you answered this. For somebody who tried Xyrem and it did not work, they weren't compatible with Xyrem, what do you suggest is the single best medicine to take at night to suppress the hallucinations, to try to get any type of
Okay.
awareness?
Yeah, I mean, if people have a lot of problems with nighttime, what we call REM, dissociated REM phenomena, such as nightmares, sleep paralysis, vivid, unpleasant dreams, then using a REM suppressant drug at night is probably the best. And the one that's been sort of most studied and studied years ago, not recently, but is a sedating antidepressant, tricyclic antidepressant, imipramine. And imipramine or tofranil is the one that many people will use to help suppress that at night. Many of the newer antidepressants, including venlafaxine and atomoxetine, can increase alertness, and so they can be more disturbing to sleep at night. So the new ones, although they're very good during the day for cataplexy, not so good at night for suppressing those REM phenomena if you need something. So it's the older, more sedative type of antidepressant drugs that seem to be the best. I'm afraid I got waved at. We're going to have to stop, but thank you for your attention. I'll be happy to answer any questions afterwards.